So here's an example of this type of late-term response. So here we see a graft with the endothelial cells, and these alloantibodies might bind the HLA molecules that are on the surface of the donor endothelial cells. This recruits inflammatory cells and leads to a low-grade inflammatory response. Over time, this chronic small injury will lead to the buildup of collagen in the endothelial vessels, which narrows those vessels, you can see here, and also causes an inflammatory cell influx into those walls. And this leads to artery damage and can cause the potential eventual rejection of the organ. So I've mentioned immunosuppressive therapies, and as we talked about in previous lectures discussing monoclonal antibody therapy, this is also very important for transplant rejection. So here we can see antigen presentation from a dendritic cell to a T cell. And then there are multiple targets here shown in red that are targeted by immunosuppressive therapies. And this helps prevent that acute rejection of the transplant organ. And we talked about some of these in more detail in the autoimmunity lecture. So you guys can feel free to refer back to that lecture or to the first half of chapter 15 in the book. So another very important problem that's often seen with transplants is known as graft versus host disease. And graft versus host disease, or GvHD, is seen typically in allogeneic hematopoietic stem cell transplants, or a bone marrow transplant. And in the bone marrow, there are mature T cells often present. And these mature T cells are from the donor and therefore recognize the recipient as non-self and foreign. And so here, conversely to what we saw with transplant rejection, here the graft actually attacks the host. And this can lead to a severe systemic inflammatory response, which leads to problems such as rashes, diarrhea, and more severe symptoms such as liver failure and death. And this is most aggressive when the MHC molecules are mismatched. And so this aggressive response is usually not seen because we now have the ability to match MHC quite well. And there are ways to test for if it's likely if this is going to happen. So, for example, you can do what's called a mixed lymphocyte reaction. So this is an in vitro experiment where donor lymphocytes are removed from the bone marrow and mixed with irradiated lymphocytes from the recipient. And here we can then observe whether those donor cells will attack and kill the recipient cells. And if they do, there's a high chance that the donor cells in the graft will attack the cells in the recipient. So we can see here an example of graft versus host disease. So first we have an allogeneic hematopoietic cell transplant. And in this case, the transplant contains donor mature T cells. These T cells then circulate throughout the body in the blood and move to secondary lymphoid tissues. And here those alloreactive cells interact with dendritic cells of the recipient and proliferate. And then those differentiated T cells, both effector CD4 and CD8 cells, can enter the host tissues and cause cell death and injury. And here we can see an example of that mixed lymphocyte reaction. So if we mix the donor and recipient cells, here shown in blue and yellow, then we can measure how much the T cells proliferate and how much they kill other cells. And these measures give us a good idea of how aggressive that graft will be at attacking the host. So there actually, while this seems like a very detrimental process, and it often is, there are some positive effects of graft versus host disease. And this is known as graft versus leukemia. And because HSC transplants are typically given to patients with blood cancers or leukemias, in this case, the donor leukocytes will actually attack the circulating leukemia cells, which helps clear the cancer from the body. Now, Gvhd can be reduced, the risk can be reduced at least, by removing mature T cells from the graft before it is transplanted into the recipient. Unfortunately, this does require a bit of a balance because removing too many of those mature T cells can lead the recipient open to opportunistic infections. And that's because the recipient must be irradiated. Their bone marrow must be killed off before they can accept the donor bone marrow. So they're very immunocompromised for a period of time. So you need some of those mature T cells for the short-term response against pathogens, but you also want to make sure that you remove most of them to reduce the risk of Gvhd. So there's really a tricky balance here between the risks of Gvhd and immunodeficiency. So one possible thing to consider with grafts is the role of regulatory T cells. And here we've seen in mice that depletion of Tregs in either the recipient or a bone marrow graft can accelerate the development of Gvhd and death. And conversely, supplementing a graft with Tregs can help suppress Gvhd with very few other off-target effects. We also see some Tregs, they're a subset known as CD8 positive, CD28 negative T cells, can help maintain tolerance of a graft by inhibiting activation of CD4 T cells. So finally, we're going to kind of pull some of these ideas together to discuss the fetus as a tolerated allograft. And this is a really interesting concept because the immune response during pregnancy is still not very well understood. However, a fetus, because it contains genes from both the mother and the father, which you can see here in this figure, blue and pink, and then the fetus has aspects of both. This makes the fetus non-self compared to the mother. However, the fetus must be protected from the mother's immune system for the 40 weeks of development. And it's likely that there's a variety of contributing factors to this tolerance of a fetus. And one of the main things is that the placenta seems to do a pretty good job of sequestering the fetus from the mother's T cells. And this is particularly important in later trimesters, as initially the placenta is still developing. However, trophoblasts, which are the main cell type at the maternal-fetal interface, are unique in that they do not express MHC2 molecules, and they do express a very restricted subset of MHC1. And these are very special because this prevents T cell activation and killing by the mother's T cells. And it also, this subset of MHC1 is protected from NK cell killing, where we'd normally see that NK cells kill cells without expression of MHC. There are other environmental aspects at this maternal-fetal interface that help protect the fetus from the mother's T cells. So, for example, specific enzymes at the maternal-fetal interface will deplete nutrients such as tryptophan. And tryptophan is very important for T cell activation. So these enzymes, therefore, by reducing tryptophan, reduce the responsiveness of any T cells at that interface. We also see a cytokine milieu of cytokines that enhance induced Tregs while suppressing effector T cells. And this really helps to reduce the amount of inflammation at that interface and further prevent the T cells from attacking the fetus. And maternal stromal cells can also repress T cell attracting chemokines. So this helps reduce the signals to T cells in the body to come to that area. So it prevents migration of T cells there. So one interesting thing is that women who give birth actually do produce antibody against paternal MHC. However, these antibodies are typically not enough to lead to rejection, because while antibody can pass through the placenta, the additional immune responses required for rejection cannot occur because of all this blockage of T cell response. So with that, today we covered some of the details of organ transplant, including the role of the adaptive immune system against an allogeneic graft. In particular, we saw how T cells and MHC are particularly important for graft rejection. We also saw the role of alloantigenic peptides in late-term or slow organ transplant rejection. And we saw a little bit about how anti-graft antibodies can lead to hyperacute rejection or chronic injury to the graft. In this context, we also discussed late-stage graft failure and how over a period usually measured in several years, most grafts still have a fairly high chance of rejecting over that amount of time due to this low-grade chronic response. Then we also discussed graft versus host disease, where the leukocytes in the graft attack the recipient. And finally, we tied some of this up by thinking about the fetus as a tolerated allograft. So I hope this helped tie some concepts together from previous lectures, and thank you guys very much for listening.